going to talk about PCI guidance with AI analysis. These are my financial disclosure. Okay, what do we know? We know that IVUS guided, I should say, intravascular imaging guided PCI is superior to angiography guided PCI. There have been so many studies showing that. For example, in this graph, you can see that when it's IVUS guided, the target vessel failure is just 2.9 compared to angiography guided, which is 5.4. And it was for 1 year, and the result is consistent after 3 years. So again, when we talk about target vessel failure, we're talking about death from cardiac causes, target vessel related MI, and clinically driven target vessel revascularization. So after 3 years, we see the same result when it's imaging guided PCI, which is way superior to angiography guided PCI. Also, there was a publication last year that showed that when it's imaging-guided PCI, anything that comes to TLF, cardiac death, target vessel MI, TLR, all MI, and all causes of death are inferior to angiography-guided PCI. So how come we know all that? And this is a very famous slide of Gary Mintz that show all the study that has been done, and this has been updated in 2025 regarding the superiority of intravascular guided PCI compared to angiography. So there was about 132 registry, 54 randomized trial, and 95 meta-analysis. All that proved the superiority of intravascular imaging guided PCI. So we know that intravascular imaging guided PCI is very superior. So how come we don't use it in the world? For example, the number one country that uses the most imaging guided PCI is Japan. 85% of the cases are imaged, followed way behind by Korea, and then in Europe you have the United Kingdom. In the United States, we're way behind. It's less than 10%. I don't know the numbers here in India. I wanted to know that. I wanted to ask that question at the end. We have all these studies that show that, and we don't use it. There was a survey that we're given to interventional cardiology fellows, and that survey, it was about 5 years ago, and we were asking them how comfortable they were using, how comfortable is it for them to use physiology or imaging. And we see the vast majority are very comfortable using physiology, 95%. Then when it comes to imaging, it was IVUS, then OCT follows. But when we asked them if they were able, from the beginning, setting up the machine, doing the imaging or physiology, and doing the interpretation, you can see that the numbers lag behind. So this is where AI comes in. The lack of physician training, maybe that's what leads to misinterpretation. So AI is very helpful in the interventional cardiology field because it will give more accurate diagnostic of the imaging interpretation. These past years, there were a lot of publication in machine learning in AI, and the goal was to show that the machine learning, the AI, was as accurate as the expert segmentation. The first machine that were created, it was like the traditional filter design and the pattern of recognition design. That was not successful. We had to wait until the convolutional neural network, we call it CNN, it became successful. Why was it successful compared to the other one? Because this one has more network. And they were gathering like a lot of parameters, and using those parameters, they tried to train the parameters to provide the input, and then a lot of segmentation that will lead to an output, and the output will be similar to the input. So the input is the IVUS image, the output is the AI that we're getting. And these are examples of what we're done. And this is another example in a study. So to summarize this, the input again is the IVUS image. It goes through a lot of training, a lot of segmentation, and we lead to our output, which is A prime, but the resolution of the input and the output should be the same. Now, studies show when it comes to AI, for example, when we talk about the vessel border, if you see, the more you see the vessel borders, if you see more than 270 degrees of the vessel borders, at that moment, the correlation between the expert segmentation and the machine segmentation is very close. On the other hand, the less you see the vessel borders, like if you see on the right, if it's less than 180 degrees, the correlation is less. Again, to show the correlation of the machine learning and the human expert, if you measure the vessel diameter, just the vessel diameter, the correlation is 70%. If you add the lumen diameter, the correlation jumps to 92.4%. If you measure just the lumen area, it's 85.5%. But when it comes to stent area, machine and expert are similar almost. And this is also to summarize that lumen area and vessel area, because the AI got so well nowadays, that when you see the lumen area and the vessel area, is more than 90% correlation. Now, let's talk about, for example, the AVIGO, the automated lesion assessment. Once you click on that, the number one you see is the vessel and the lumen borders. The number two is the vessel and lumen profile. I'm talking about the longitudinal view. Then you see the MLA. You don't have to look like we used to do before in IVUS for the MLA. That's the difference between IVUS and OCT. And then also it shows you the frame markers, so you can put your distal reference, your proximal reference, and then you get a length. Now let's do quickly this case. It's an 85-year-old male that had CAD with risk factors and a low EF. He presented with chest pain, and you can see that the proximal LAD is diseased, and also we were thinking the distal left main. When we did the IVUS, the first thing on the left side that I will advise the fellow is the first pullback, you have to choose 1 millimeter per second. Unless it's a long pullback, I choose 2 millimeter per second. Then after, when I know my picture, when I put the stent, I go to 3 millimeters per second. So this is an IVUS. So you get some calcium, and you will see almost at 3 o'clock, the second dia coming in. You have some disease, but it's not obstructive. As we're going more proximal, watch carefully, then you see D1, that is wired, comes in, and you see a thrombus between 6 to 8 o'clock and 360 degrees of calcium. And let's continue, and you will see very soon the left main. Remember, we thought that there was a disease in the left main, and just by eyeballing, it looks like borderline. So what did we do? We click on the AI. I got a distal reference and a proximal reference. Just remember that references have to be any stent has to land, if possible, in a place that has less than 50% black burden. And this is a summary of the pullback. So you have the minimum lumen area 1.8, and proximally you have 360 degrees of calcium, and you have a thrombus protruding in the lumen. So what did we do? We balloon because of the calcium, and what are we expecting to see? Calcium fracture, you see it at 12 and at 3 o'clock. So again, we balloon, and these are the fracture at 1 o'clock and 3 o'clock, and you have luminal gain. The lumen went from 2.0 to 4.1. And this is the final IVUS. The distal edge there is no dissection or hematoma. The stent is well expanded, and the MLA was 7.8. So, and the final angio. And of course, I forgot to add, when we measured the distal left main, it was 6, so it was borderline. We decided not to touch it. My conclusion is, we know that AI has proven to be very accurate and very reliable when you compare it to manual segmentation. And hopefully, because we have more AI nowadays, hopefully in the world we'll be using more imaging, intravascular imaging, when we will do PCI, because it will be better operator efficiency, less radiation for the operator as well for the patient, and also with the new guideline, the ACI guideline, I hope that people will think about using more intravascular imaging, and we have the AI that gives everything on a platter. Thank you.
Thank you, ma'am. Is there any difference between the AI measurements of IVUS versus AI measurements of OCT, Ultron and Evigo?
Yes, but there is a very, very tiny difference because we have to remember that OCT has a higher resolution than IVUS. So it's like about 0.0025. It's very negligible, but yes, there is, but it's not significant. And I just wanted to ask a question. What's the percent of intravascular imaging in this country? How do they use it with PCI? Is it less than 10% or more than 10%? Okay.
But it's increasing. Picking up.
Okay.
Picking up. Okay, ma'am, thank you.